thank you to Visunex for the opportunity to talk to you. I'm excited to tell you about this new product and why we think it's going to be greatly valuable for screening for all healthy newborns, newborn babies. So Pediatric TeleOphthalmology has come a long way. In the last decade, we've used RetCam screening, a camera made by Clarity, to image the fundus of babies with retinopathy of prematurity. And with those images, we've been able to demonstrate that screening is as good as indirect ophthalmoscopy, and babies can be screened remotely, and those images can be viewed and analyzed to see whether or not they need to be treated. So 2 major studies were done, the ROP study, which showed the validity of identifying any stage of ROP with telemedicine, and they showed that that was at least equivalent to indirect ophthalmoscopy, and the SUNDROP trial, which was done at Stanford, which demonstrated the efficacy of telemedicine to identify treatment-warranted or referral-warranted retinopathy of prematurity. Based on those results, a major study was done called the ROP study, and that showed that non-physician imagers and non-physician graders could identify babies that had referral-warranted retinopathy of prematurity. Based on that study, we think that the use of telemedicine in screening babies was really validated. Now the question is, can we extend that beyond disease, beyond children that we know are at risk for disease? So why are we interested in screening healthy newborns? The main reason is to try to identify children that are at risk for developing amblyopia. So children that develop amblyopia, about 2 to 4% of them, it's the #1 childhood disability, the fourth most common disability overall, and it's the #1 cause of monocular vision loss in the young population. But unfortunately, we don't identify children that have vision loss until they're school age. In the US, we start seeing if children have any problem with their vision at around 6 years of age. That's when the first formal eye exam occurs. It's in the kindergarten or school-age children. But at that point, they've already developed, in some cases, they've developed irreversible vision loss, or irreversible blindness in some cases, which is dense amblyopia. Now, multiple government agencies and private foundations have recommended that we screen earlier. The U.S. Preventative Task Force recommends vision screening at age 3 to 5, and the American Academy of Pediatrics recommends vision screening of age 3. But we don't do that, mostly based on convenience, because the first time that we start enrolling kids for vision screening is at school age. But perhaps they actually have something that's preventable if we identify it earlier. And when we think about prevention, there's 3 different categories: primary prevention, secondary prevention, and tertiary prevention. Let me give you the analogy of diabetes. In primary prevention, we would prevent the disease. That would be like treating people with diabetes with insulin. Secondary prevention, we prevent blindness from the disease. That would be like people who have proliferative diabetic retinopathy delivering laser. Tertiary prevention is treating the actual disease itself, like doing a vitrectomy for a patient with a vitreous hemorrhage. Newborn eye screening is a form of secondary or tertiary prevention, because if we could see these very early, such as a retinal detachment, which is imaged here with the new camera, or a retinal hemorrhage or a cataract or retinoblastoma, we may be able to intervene earlier and prevent dense amblyopia or vision loss. We think that early intervention will prevent vision loss, particularly in what we expect to be the largest population that we identify, which is patients who have hemorrhages. So vitreous hemorrhages and macular hemorrhages happen commonly because of birth trauma. And I'm going to tell you a little bit more about that. But we could also identify other diseases, persistent fetal vasculature, very early, before the eye is growing, and intervene, or even save life by identifying very early and small retinoblastomas. So let me hone down a little bit on this idea of hemorrhages. So multiple studies have shown that the rate of hemorrhages is very consistent across multiple populations. In Brazil, any hemorrhages were identified in about 10% of newborn babies. In China, it's about 21%, and in Spain, about 9%. So somewhere between 10 and 20% of babies have hemorrhages somewhere in the fundus. In the fovea, it's somewhere between 2 and 4%. So 1.8% in Brazil, 1.7% in China, and again 1.7% in Spain. Now, most of those hemorrhages resolve, and we know that. But we also know that hemorrhage causes visual deprivation. They usually resolve in about a month, but it only takes a month to have the visual deprivation that leads to amblyopia. The average time for the hemorrhage is 3 to 4 weeks. It can be monocular or binocular, but in those eyes, we know that that results in very high myopia, sometimes greater than 10 diopters of myopia. On average, actually, it's 11. And we think that it's possible that those anatomical changes affect the function of the eye. So we don't see them because they resolve after a month, but in the eyes, particularly in monocular eyes that have fovea-involving hemorrhages, those may be the eyes that result in large amounts of myopia, resulting in large amounts of anisometropia and amblyopia in the particularly myopic eye. So amblyopia occurs 4 to 12 weeks after some kind of visual deprivation. We know the hemorrhage can cause that kind of deprivation. Myopia follows the hemorrhages, and if we can identify those eyes early, we're not going to do anything about the blood unless it's a large vitreous hemorrhage that doesn't clear. But in hemorrhages that are intraretinal, in the fovea, we can identify those kids, follow them, and hopefully refract them and prevent long-term vision loss from amblyopia. So the idea is teleophthalmology can identify and follow the children at risk and prevent amblyopia. And with a percent like this, something like 1 to 3%, we think that we could affect large population by screening all babies. Now, what would we need to do to screen? We need to have the right hardware and the right software. And that's where the PanoCam comes in. So for hardware, if you think of what you'd want great image quality, excellent resolution, good color richness, capable of imaging a light fundus or a dark fundus so you can image any population. Portability, so you could take it from the OR to the NICU or birthing center or in your office. Ease of use, anybody could take these pictures. Like the ROP trial showed, it could be non-physicians, nurses, technicians, anybody could put the camera on and take the picture and get a clean image. Now on the software side, we'd want to have secure capture and sharing. That's very important that it's HIPAA compliant. We want to be able to catalog those images and the data, and we want to be able to access them from anywhere. So if you have a non-physician that's taking pictures 100 miles away, the images can be read by the physician at their office. They don't have to go there, and the images don't have to be transferred from the device to some other third party. They could just be integrated. That would ease the use and limit error. So Visunex has made this fantastic camera, the PanoCam LT. It's able to get 130-degree field of view. It's portable, non-tethered. It's a single handpiece. It has a new generation of LED lighting technology, which gives an even illumination and is capable of imaging light and dark fundi. And it has this fantastic software, which is a cloud management system, which allows global access to the images anytime, anywhere, by anybody. The structure is like this. The pictures are captured by the portable device. The images are uploaded to the cloud, and any device is capable of viewing them. A tablet, an iPhone. You don't even have to be at your office to see the images. You can see them anywhere. And for those eyes that need to be followed, we can flag them, identify them, and then those patients can be referred. And we're validating that now. We really don't know if the theory that identifying these hemorrhages is going to prevent amblyopia, but that's why we're going to look. So we're doing a very large study, the GUEST study, which is the Global Universal Eye Screening Testing. It's an international study, a collaboration between China, United States, and Brazil. It's a defined protocol. We're trying to identify the screeners with the least amount of training and the highest level of agreement, and we're also going to identify those patients and follow them for the future so that we can identify the amount of myopia in those eyes, and if intervening earlier will prevent long-term vision loss. So just to summarize, we think it's now possible, due to this fantastic new technology, to accomplish these goals. We think it's the right time to start doing universal screening of all babies. It will be safe, it's easy, and we think it's going to prevent vision loss in a large population. With a portable camera, simple image capture for any user, excellent quality and cloud-based technology, we have all the features we need to do these studies now and to answer whether or not identifying the pathology early is going to prevent blindness. So we want to identify this disease early, intervene early, and possibly prevent amblyopia. So our validation efforts are in progress due to international collaboration, and we look forward to using this device to answer these important questions. So thanks very much.